So this was an oral presentation that provided the updated analysis from the KarMMa-3. So probably, as you all know very well, KarMMa-3 is a Phase III randomized study that compare Idecabtagene vicleucel versus standard regimens in patients with early line relapse and triple-class exposed relapsed refractory multiple myeloma. So in the presentation, we gave the final PFS analysis as well as the the first disclosure of the interim overall survival data with a median follow-up of 30.9 months. So probably everyone is already familiar with the study design. So just to briefly mention that the patients that were eligible for KarMMa-3 were randomized 2-to-1 to receive Ide-cel or standard regimens, and that patients that were allocated to the standard regimen arm could cross over to receive Ide-cel infusion after confirmation of disease progression. So regarding the progression-free survival final analysis, so with the extended follow-up with a median follow-up of 31 months, so Ide-cel continued to show a significantly longer progression-free survival versus standard regimens with a median PFS for Ide-cel of 13.8 months and a median progression-free survival for the standard regimen arm of 4.4 months with a hazard ratio of 0.49. And also with the extended follow-up, Ide-cel continued to show increased overall response rate and also increased complete response and MRD negative rate among patients in CR. Likewise, both median duration of response and median progression-free survival too were also longer for Ide-cel as compared to the standard regimens. So regarding the overall survival analysis, so with the median follow-up of 30.9 months, the median overall survival in the Ide-cel arm was 41.4 months versus 37.9 months with a hazard ratio of 1.01. So it is important to highlight, to really understand the overall survival analysis, that first the study was not designed to provide definite conclusions regarding overall survival. And moreover, the patient-centric design allowing for crossover really confounds the overall survival interpretation. So importantly, 56% of the patients that were treated in the standard regimen arm had already received Ide-cel after crossover, and crossover could occur as early as by month 3, with a median time from randomization to Ide-cel infusion in the standard regimen arm of 8.1 months. So when we perform the planned sensitivity analysis adjusting for crossover, so we do see an overall survival benefit in favor of Ide-cel with a hazard ratio of 0.72. So in conclusion, I think that this extended follow-up continued to show the benefit of Ide-cel in patients with early line relapse and triple-class exposed relapsed refractory multiple myeloma, and continue to show a significantly longer and clinically meaningful improvement in progression-free survival with Ide-cel versus a standard regimen, which was the key primary endpoint of this study.